Welcome back, everyone. Okay, so we have Dr. John Wagner with us. He is a registered psychologist in British Columbia, the director of the DBT Centre Vancouver, a clinical associate at Simon Fraser University, and an adjunct professor at the University of British Columbia. In addition, he is certified as a DBT clinician by the DBT-Linehan Board of Certification. Welcome.
Thank you, Bailey. I'm happy to be here.
Great. All right. Well, we'll start off with just asking, what is BPD? Maybe how do you be diagnosed, and a little bit about the biosocial theory?
Sure. So when we look at borderline personality disorder, it's a disorder that is characterized by 9 criteria and/or symptoms. In order to meet criteria for the disorder, you need to meet 5 of those 9. And so I think one of the important things to keep in mind is because of that, we can see 2 people who meet criteria for borderline personality disorder that can present as quite different. Because again, we may have one individual that's meeting 4 different criteria than might be the other individual. But if we take a look at this a little bit more closely, there's 9, and really, again, the order doesn't matter all that much. First criteria is frantic efforts to avoid abandonment. And what this can include is people doing things that they later regret in an effort to keep other people around. It could include repeatedly following up with somebody to the point that it becomes bothersome for the other person. It can include threatening to hurt ourselves and or other people at moments in time as well. The second criteria is unstable interpersonal relationships that are often characterized by oscillating between extremes of thinking very highly of the individual and idealizing the individual and devaluing the individual, and are thinking quite poorly of them. And in some ways, this may be due to our emotions, in the sense that when we're feeling stronger emotions, whether it be love, attraction, interest, or anger, sadness, or fear, that's often going to influence what we do. And so in considering the unstable interpersonal relationships, that can look like, for instance, somebody having a difficult time being able to maintain lasting relationships with people. These are often people who sadly don't have many friends, who oftentimes tend to rapidly cycle through friendships or other relationships as well, and who oftentimes, as a result, are finding themselves feeling quite lonely at times. Third component of it is what we might call an unstable sense of self. And so this is where people diagnosed with borderline personality disorder often don't feel like they know who they are, or may notice that rapidly changing. This could be, for instance, acting dramatically different among different groups of people. This could be changing political views somewhat rapidly, religious views somewhat rapidly, and or other things such as that. Let's see, we're at 3 here. Number 4 would be troubles with impulsivity. And so this can include engaging in impulsive behavior in at least 2 areas that are damaging. This could be reckless spending, reckless driving, reckless sex, reckless substance use, a variety of things right there. And again, in order for somebody to meet criteria for BPD, they would need to meet being struggling in at least 2 areas. Fifth component of that would be recurrent suicidality or self-harm. And so people struggling with BPD, sadly, are often struggling with strong suicidal urges and or urges to harm themselves, and are often doing so as a result. This is one of the reasons why it's so important for us to be attentive to borderline personality disorder, because we know that the mortality rates with it are especially high. And this can include in terms of self-harm, harming self in a variety of different ways, but this can include cutting oneself, hurting oneself, doing a variety of things there. 6th symptom, and this is really in DBT, what we consider to be an especially important component of it, is mood or emotional instability. And so clients struggling or people struggling with borderline personality disorder oftentimes notice themselves having very intense emotions that they have a hard time managing, and that can be and or lead to a lot of ups and downs throughout the course of a day and or more, going from feeling extremely happy at one moment in time to extremely sad at the next moment. We might notice other emotions as well, fear, shame, other things such as that. All right, I might be losing track of where I'm at. I'm thinking I'm at 5 or 6 here, so let's look out for what else I'm missing. Another one that often goes along with it is difficulties managing anger. And so people struggling with BPD will often experience not only problems with sadness, fear, and or other emotions such as that, but they also have a hard time in being able to manage their anger and may sometimes find themselves getting into trouble as a result of that. Number 8, I believe, is chronic feelings of emptiness. And so this is where people are often reporting feeling quite empty inside, and this can include whether around other people or not. And then the last one is dissociation or feelings of paranoia when stressed. And so this is when people are finding themselves feeling especially stressed out. They might be more likely to zone out for periods of time, kind of forget what had been happening. This can include oftentimes suppressing thoughts, feelings, a variety of internal experiences. And that could also include thoughts like others are out to get me or increased difficulty trusting others as a result. And so I hope that was all 9, I believe.
Yeah, no, I think you did great.
All right, very good.
Yeah, could you speak a little bit to the biosocial theory for a moment?
Sure. And so, one of the other questions people often have is, well, if I'm struggling with BPD or if I have a loved one who is struggling with borderline personality disorder, what is it that tends to contribute to this? And there are a variety of different theories out there, but what I can talk about is Marsha Linehan, who developed dialectical behavior therapy, her biosocial theory. And the theory kind of goes like this, which is we all really essentially vary in terms of how emotionally vulnerable or sensitive we are. And we could view it almost like a bell curve to some extent, in the sense that on one end, there are those of us that are especially emotionally vulnerable and or sensitive. And when we talk about emotional vulnerability, that can include sensitivity, that is how easily are our emotions triggered. This can include reactivity, which is how intense do our emotions tend to be. And then the third component of it is slow return to baseline. And so this means my emotions are easily triggered, they're pretty intense. It's oftentimes going to take them longer to come back to some more level of normal or baseline. And I say we can view this on a bell curve because there's some of us that are going to fall more over here on the highly emotional side, and there's others that are going to fall more on what we call the hypo-emotional side. And I think it's always interesting to look around and consider where we ourselves might fall in comparison to other people we know. My wife and I are always a great example, and one situation I may give is my wife and I live in a duplex here in East Vancouver, and we have worked very hard to get into this place. And so we moved in there about 10 years ago. And I remember soon after moving in there, we had a dinner party, and we had a couple of people over. And in the middle of the dinner party, somebody says, "Oh, this is a great starter home." And I remember thinking to myself, I remember finding myself feeling so angry in that moment, barely holding my mouth together in an urge to kind of yell at him or say, "How dare you?" So I managed, using some of my DBT skills, to make it through the dinner. And then lo and behold, after the dinner, I finally am alone with my wife. And I say, "Gosh, Krista, I can't believe they said that." And she's like, "I don't think it's that big a deal. And I don't think they really meant much by it." And so I say this because just biologically, I'm a much more emotional person than my wife. And my emotions tend to be, I notice, triggered a little bit more easily. They tend to be a little stronger. And sometimes as a result, they take a bit longer to come back to normal. Now, as I will often point out to my wife, however, and as I think is also important for us all to consider here, is being more emotionally vulnerable isn't always a bad thing. Being more emotional, for instance, can set us up for being more passionate for life or certain things at moments in time. It might be lead us to be more motivated to do things like push for social justice at moments in time and or other things such as that. And so it's not the emotional vulnerability itself that's the problem. And in fact, what we have found in research studies on DBT is that DBT doesn't really change that emotionality all that much. In the sense that we are perhaps some people who are always going to be a little bit more emotional. But what it seems to do is it seems to teach us a variety of strategies and skills for being more effective in managing these emotions so that we don't get into the trouble that we might otherwise get into with them. And so I think that that's an important thing to keep in mind, because if we can more effectively manage our emotions, they're less bothersome to us, and we're better able to work with them then as well. As some people will say, we're kind of like super sensors to some extent, those of us that are more emotional. And again, there's some pros and cons associated with that, but there again are some benefits associated with being more emotional at times, including the fact that actually research has shown that people diagnosed with BPD seem to be better at reading other people. They've done some studies where they're, for instance, show a slow motion facial expression. Let's say, oh, I don't know if it's surprise, it's slowly moving into surprise then right there. And they'll ask people to look at how quickly they can identify the other person's emotions. And lo and behold, they discovered that people that were meeting criteria for BPD were actually quicker in being able to accurately catch the emotion at hand. I also mention this because while that can be quite beneficial, it can also get us in trouble at moments in time because it is sometimes hard to be more sensitive to other people's feelings. And there's sometimes some benefit in being able to let go of that at moments in time as well. So without going off too far on a tangent right there's the emotional vulnerability section of it.
Right. And then you mentioned there's some other theories on like contributing factors to BPD also.
Most definitely. And so as we talk about the biosocial theory, it's the emotional vulnerability in combination with not learning to effectively deal with those emotions. And researchers will sometimes also take a look at what we call invalidating environments. And when we talk about that, what we're essentially getting at is if you're a highly emotional person who's paired with somebody, let's say, who's less emotional, they're oftentimes not going to be able to understand where it is that we're coming from. They're going to not know how to respond to it in the same ways. And so there can be a tendency at times to dismiss or reject what we call emotional communication. If I'm repeatedly saying I'm in great distress, the other person doesn't understand why it's happening or what to do about it. There can be a tendency to say things like, you know what, I think you're overreacting, as I know we're all going to perhaps do with our loved ones at moments in time. But it's those repeated things that can lead to problems with more effectively dealing with our emotions. Another thing that can get in the way of us learning to more effectively deal with our emotions is also what we call a tendency to oversimplify the ease of problem solving. And so these environments at times can convey that it's easier to deal with the problem than it actually is. It oftentimes gets in the way of us being able to better persist in the face of obstacles because we may see ourselves as the problem rather than the situation itself. And then the final component of what we, again, sometimes call an invalidating environment is it tends to, what we say, intermittently reinforce emotional escalation. And I know that's kind of wordy there, but what we really mean by that is somebody's expressions of emotions like I'm having a hard time or other things is not being responded to. And so what happens is when they engage in more extreme behaviors, whether it be yelling, throwing things, sometimes engaging in self-harm, it's only at that point in time that additional assistance is provided. And so we can see how people might be more prone to engage in those behaviors as a result. And so it's a combination of those two different things that we would say often contributes to BPD. Now, there's also been some additional research, just to add one other thing, and they've also found that as another biological component, people struggling with BPD also tend to be more impulsive. And it's what we call sometimes trait impulsivity. It's one of those things that is with it. It can be characterized by things like ADHD, for instance, and or other conditions as well. But there's been some new research suggesting that people with BPD are oftentimes more impulsive, perhaps temperamentally to some extent in addition.
Okay, great. Well, thank you for that. That was very thorough. I appreciate that because some people are just in the beginning of their journeys. They're getting newly diagnosed, or maybe family members are wondering about what BPD is. So I really appreciate that. And for people who are unfamiliar what DBT is, could you describe it for us and maybe some of the research behind it?
Most definitely. Yeah, so DBT stands for dialectical behavior therapy. I realize that's kind of a big term itself again.
So many acronyms.
Yeah, and as you know, there are so many different acronyms we use in DBT as well when we're trying to summarize specific skills. But dialectical behavior therapy is a psychological treatment that was developed by Dr. Linehan, who was a professor at the University of Washington. And She was initially interested in working with people struggling with recurrent suicidality and self-harm. So these are people who are oftentimes thinking about suicide, perhaps planning for attempting suicide, and are also engaging in self-harming behaviors as well. And as she worked with more and more of those individuals, she found that many of them also met criteria for borderline personality disorder. And so it's in that way that DBT has now come to be the most well-researched psychological treatment for borderline personality disorder. And more specifically, what it involves is a combination, when we're talking about comprehensive DBT, of 4 different things. First of all, there's individual therapy, which is generally done once a week for about an hour, 50-minute to a 60-minute session. And what we're doing there is we're focusing on the individual problems that the person is struggling with, and we're diving into those a little bit more deeply. We're oftentimes seeking to get a better understanding of what's prompting those problems, and then we're focusing on trying to teach a variety of skills or strategies for more effectively dealing with the problem at hand. A second component of DBT are these skills groups, and these groups are generally about 2 hours or so in duration. And those are more like a class than anything else, in the sense that what they're designed to do is to teach clients a variety of strategies for more effectively dealing with a number of the things that might get thrown our way. We spend 6 weeks on mindfulness, teaching people how to be more aware of what it is that's going on so that they can more effectively cope with what it is that's going on. We teach them how to be more attentive to the present moment, more attentive to their internal experiences, and also how to be a little less judgmental towards themselves and others at moments in time. We'll spend 6 weeks on distress tolerance, and this is teaching people strategies for more effectively getting through distressing situations without doing things we later regret. You know, again, we could look at this as suicidal or self-harming behaviors, but this can include other things as well. Yelling at people at moments in time, maybe certain substance-related problems or such. We'll spend 6 weeks on interpersonal effectiveness skills. So these are skills for more effectively coping with and interacting with other people, being more skillful in asking for what we want, strategies for building and maintaining better relationships, and also strategies for maintaining our self-respect in the midst of this. And then finally, and often now, we're spending 6 to 8 weeks on emotion regulation. And so this is when our emotions are having lots of ups and downs throughout the course of the day. How do we level that out to some extent? And so it's teaching people a variety of different strategies for doing just that. And then the fourth component is for the therapists, and that is the therapists get together once a week so that we're talking about cases and how we're doing with those cases. So not only are we being as effective in helping our clients, but we're also doing what we can to take care of ourselves. So those are essentially the 4 components. I think just 2 other things that I might highlight is one of the other reasons we believe our clients struggle the way they do is because they don't have skills for doing otherwise. So one of the big things we emphasize in dialectical behavior therapy is, again, skills training, teaching clients a variety of different strategies or skills so they can more effectively cope with the situation at hand. And in fact, if you give me a moment, this here, if you're curious about the skills and strategies, is what you might get, is these DBT skills training handouts and worksheets. And this could be ordered on, most places, Amazon, Google, whatever else it might be. The other thing I also wanted to mention as I'm thinking about it is also what I find is quite interesting and inspiring in many ways is that Marsha Linehan, who developed DBT, about 10 years ago started talking about her own personal problems. And it turned out that in adolescence, she struggled with many of the problems for which this treatment was developed. She ended up spending much of her adolescence on inpatient units. And at the time, when they went back and looked at records, people were saying, this is an impossible to treat person. And I mention that because, number one, it's interesting to think how that must have influenced her development of the treatment. Secondly, is I also think it highlights the capacity for change. And so we may not all go on to become the famous psychologist that Marsha is, but I do think it shows that we can all get better from these things.
Mm-hmm. Yeah, and touching on that, like what are some of the treatment outcomes for people with BPD who go through dialectical behavioral therapy?
Very good question. And of course, it's going to vary from study to study. But what we do know is DBT, number one, is the most well-researched treatment for borderline personality disorder. And there's been over 40 randomized control trials across the world looking at DBT. Now, randomized control trials are kind of the gold standard for assessing many treatments. And what they're essentially doing there is assigning people to one of two conditions. They could assign them to a control condition where they're getting one type of treatment or more, let's say, treatment as usual services. And then they're assigning another group randomly to DBT treatment. And that's one of the ways in which we can see is that the treatment itself or some other variable that might be contributing to the treatment and or the gains. And what we find is DBT seems to generally be more effective than the conditions they're being compared to in a variety of different areas. Number one is DBT has been repeatedly shown to reduce the severity and frequency of suicidal and self-harming behaviors. It's been shown to reduce the number of emergency room visits that people are making. It's been shown to increase people's retention in treatment itself when needed. And so one of the problems associated with borderline personality disorder and or some of the things that go along with it is that clients oftentimes tend to rapidly cycle through treatment providers. Sometimes the dropout rates, for instance, for some of the studies they're comparing it to have been as high as 60%. So if you're dropping out of treatment prematurely, the problem is you're not going to benefit from the treatment. And so with Marcia's studies, what they found in many is retention rates of 75 or 80%. And again, I think that shows that DBT seems to be doing a good job in generally working with many clients so that they're able to stick with the treatment and benefit from the treatment as a result. Some of the other things that they've shown is DBT seems to be pretty effective in reducing certain substance use, and it's been used in a variety of other things as well. Now, when we look at the effectiveness, for instance, in regard to things like suicidality and self-harm, again, it's going to vary from study to study, but we're seeing success rates somewhere between 60 to 90%, oftentimes in the 80 or so % range with many of the studies on DBT. And so it's certainly far from perfect, and it shows that we still have a lot of work to do as a community, as mental health providers, treatment developers, and such. But what I think that this does highlight is DBT at least is seeming to be a pretty good treatment for dealing with many of the problems at hand.
Thank you. Is there any current literature on COVID and BPD, or what have you noticed are the experiences of people living with BPD during COVID? I know it might be too soon, but
it's an excellent question, and as I pause to consider it, number one, I haven't seen any studies yet. And so that doesn't mean there may not be one or two out of there, but it certainly means that there's not many out there right now. And so really in many ways, I guess I'm thinking back to my own personal experiences. And I think, again, there's been variability. I was interested to read recently that at least during the first 6 months to year of COVID, that suicide rates actually were declining in some areas. And that was a bit of a surprise given some of the other things that we have been hearing. And so there's more research and or studies to be done right there. But I've noticed, some variability there. Number one is I think in some ways BPD has, for better or worse, equipped some of our clients for being able to deal with crises such as these because they have dealt with so much in their lives. And so as for somebody who has not dealt with psychological difficulties, this is a cue that's prompting all kinds of stuff that they don't have any experiences with. But there's many who have had to cope with so many difficulties, challenges in their life that in fact, I found them better equipped than some others I know at times in being able to deal with this. But then, of course, I think the other thing that's valuable to keep in mind is that it's also obviously extremely difficult. There's the isolation, difficulties in being able to do things, socialize with others, and then, of course, other things, loss of jobs, loss of income, loss of family and or loved ones at moments in time as well. So I don't know that I can say much more than that.
Oh, I think that's perfect. Thank you. What are some effective ways that loved ones can support a person living with BPD, such as validation or any other recommendations?
Yeah, I think it's a wonderful question. And I think, I recognize that it can be very difficult. One of the hardest things is to see our loved ones facing some of the challenges that they do. And I think one of the things that is important, as you had mentioned there, is validation. I think sometimes what ends up happening, and I know this even personally myself, for instance, sometimes with my kids, is, when they're distressed and are having a difficult time, my urge is to come in and tell them what they can do to fix it. It's to work on trying to change the situation at hand. And I think what is important for us to keep in mind is that's sometimes not what they're looking for. Sometimes when we're finding ourselves feeling distressed, what we're wanting to do is to be heard. And so looking out for opportunities in which we may do that, I think are especially useful. And validation is one of the strategies that not only are we teaching our clients, but that we're also sometimes teaching loved ones as well. And so what do we mean by validation? Well, number one, validation is conveying in some form or another that something you're saying, doing, or feeling makes sense. It's looking out for the kernel of truth at moments in time in regard to the situation at hand. And so as we try to break down validation a little bit further, some of the components are, number one, listening, appearing interested in what the other person has to say, because that's oftentimes the first step in being able to further validate the person or acknowledge how something they're doing makes sense. Second one is to really just work on trying to restate or reflect what the person had said. And so, for instance, if I'm saying I'm having a hard time, it might be saying, yeah, it sounds like things are really difficult right now. Or it sounds to me like you've been finding yourself feeling scared and or sad. That's one of the other things that we can do when we're not sure how else to validate somebody, is we can oftentimes validate the emotion. So even though we may not understand why the person is feeling what they're feeling, even though we may disagree with some of the things that are prompting it, by simply acknowledging things like, it looks like you're feeling sad right now, or I understand you're feeling upset. Again, I recognize that's not going to change all of these problems here, but it can actually be one step towards the other person being feeling better heard, and on some occasion being more likely to hear us. One of the other things that's involved in validation is also letting the other person know in some form or another how their thoughts and or feelings make sense. And so, for instance, let's say that you have a loved one who's quite distraught over the ending of a relationship. I don't know, somebody broke up with them. Even though the response might seem extremes to us at moments in time, I think, what we can do is acknowledge that for most of us, it makes sense that we're going to be feeling sad if somebody we care about has ended a relationship with us. And so that's where I'm moving from just listening to the person to trying to acknowledge or state how it makes sense that they're feeling what they're feeling. And then the final component of it, I think, is also not trying to one-up the person, being genuine, watching out for trying to take on a therapist role if you're not the therapist as well. Now, you might think, well, gosh, I do a lot of that already. And if that's the case, fantastic. I think all of us could look out for opportunities where we can further do that with other people, and then perhaps even ourselves at moments in time. How does it make sense that I'm feeling what I'm feeling? How might it make sense that I'm thinking what I'm thinking? And that doesn't mean we're always sanctioning the behaviors that go along with it. The other thing I also think that it can be valuable to keep in mind is validation can actually be helpful in interacting with our loved ones because, again, well, maybe I'll use this example right here. Bailey, let's say I'm standing on your foot and you say, hey, John, you're on my foot. And I say, no, I'm not. What are you likely to do?
It reminds me of the nail in the head.
Yeah, you got it. Very similar, yes.
Yeah, I'm going to say, but I can feel it.
Yeah, and what if I keep saying, no, I'm not on your foot?
I get louder and louder.
You got it. And I think that that's an important thing to keep in mind because when we feel like we're not being heard, what tends to happen to our emotions? They go up. When we feel like we're not being heard and our emotions go up, we're less likely to hear the other person. And we're more likely to kind of fall back on other habits that may have worked in the past that aren't working so well now. And so this is one of the other reasons why we recommend people be attentive to and continue to look out for ways that we might validate. And we recognize that people struggling with BPD will often need a little bit more validation, perhaps, than some others. But what we find is that by weaving that in and looking out for opportunities to further weave that in, it oftentimes can help in improving things and even sometimes setting the other person up as being more likely to hear and or listen to us.
Great, thank you. And what services does the DBT Center offer?
Good question. Well, we offer comprehensive DBT, and so we offer individual therapy. We have our skills groups. We have, the other component I forgot to mention of comprehensive DBT, which is between session consultation. And so what I mean by that is all of our clients have our cell phone numbers so that they can give us a call as needed, so that they can get coaching as is needed as well. And so our clinic offers that. And then finally, we offer the consultation team in addition.
And you also offer DBT for adolescents and multifamily skills?
Yes. So we work with both adults and adolescents. And so the adolescent group is for both the adolescent and their primary caregivers. So often this is, for instance, a parent or parents. And the cool thing about that is they're learning the same skills at the same time with their loved one.
Right. Okay. We have two questions if you have time. Okay. Kayla asks about complex BPD. I don't know if you mean PTSD or I haven't heard these terms before. Complex BPD and pure BPD. I haven't heard those terms before.
Complex BPD, and then the second one was?
Pure BPD.
Pure BPD. I don't know that I've honestly heard those much either. With complex PTSD, we do recognize that there's overlap. What we also know is many clients struggling with BPD have also experienced traumatic experiences in their past. Now, complex PTSD essentially just means PTSD plus other things. And we find that many of those things are what's occurring in borderline personality disorder, including the instability in interpersonal relationships, difficulty in being able to control our affect or emotions as well.
Great, thank you. And Nicole has a question. Do you have any advice for people married to a spouse with BPD when rage and anger is a concern?
Yes. First of all, that is a very difficult situation, I recognize. And so, validation can be useful, but I think the other thing we also have to keep in mind is caring for ourselves. And so, for instance, if we're not safe, and if we're not looking out for ourselves, it's going to be very hard to care for the other person. And so for those reasons, I would also think about, the importance of taking breaks at moments in time from our partners or loved ones. I would be thinking about the importance of, if you are not safe, walking away at moments in time as well. And then finally, maybe the last thing I'll offer real quick is, there's all kinds of great books out there on BPD, and I don't mean to sell one or the other over the other, but I'm thinking this is one I often recommend.
It's a great book. That's on our list of books too. Very
good. Okay. And this one, I think, talks about, many of the other considerations in dealing with those behaviors, including problems with anger.
Great. Just our last question, I'm recognizing the time. Does the DBT Center deliver their services via online right now, or is it still only in person in Vancouver?
Oh, good question. Yeah, no, with COVID, we've been doing all of our services via telehealth. And so we're doing most of those online now. I'm hoping that will change as it's safer for us to do so. But one of the pros associated with that is it has allowed us to expand services that we're offering for people outside of the Metro Vancouver area. And that's something that we anticipate continuing even when we are able to return to doing most services in office.
Great. Well, I really appreciate your time today and all of your answers.
You bet. Well, thank you for having me, Bailey.
Yeah.
Okay.
Take care.